moving on to our next speaker for the day, we have Dr. Rajesh Thalapparambath. Sir is currently working as the manager in the inpatient medication management services at Johns Hopkins Aramco Healthcare in Saudi Arabia. He has actively rendered clinical and non-clinical services and has been a key player in quality and administrative domains. An active provider of pharmacy services, Dr. Rajesh is an invited speaker for many conferences and is an esteemed member of national and international professional organizations. He has been able to publish his articles in some of the most reputed journals, and we are really excited to hear out your experience, especially in medication safety in perioperative areas, sir. Over to you, sir.
Thank you so much, and let me share my screen now. Can you see my screen now?
Yes, sir, we can.
Great. Once again, thank you so much for your kind introduction today. And that was a real interesting topic from Dr. Krishna before, and from the clinical trials, I'm just taking straight away to the patient bedside now. Just we're going to see what's going to happen at the bedside in terms of medication safety, especially in the perioperative as well as the procedural areas. Let's start with a small Chinese proverb. The error of one woman becomes the sorrow of the whole life. And that's exactly true for the medication as well as the medical errors. Medication as well as the medical errors are not only painful for the patients and the family and the friend circle, but it's a painful experience for the what we call it as a second victim. Second victim is a staff who actually committed the error or unknowingly happened to that to be in that scene. So we call it as a second victim. So this is a lifelong suffering, and we knew that there are staff, medical staff. Some of them actually they left the profession just because of one singular happened from their hand. Some of them actually have to leave the job just not because of the organization terminated them, but just because they cannot continue because of the social issues. So it's actually a lifelong sorrow. So prevention, patient safety is usually defined as a prevention of errors and adverse effect to the patient associated with the healthcare. So it's a very broad spectrum, and the medication safety is one of the subset actually, or a subset of patient safety in general. So freedom of accidental injury due to the medical error or medical errors during the medication use process is called as a medication safety. And it's a very broad definition provided by the National Coordinating Council for Medication Error Reporting and Prevention from USA. Number one, it's a preventable event. So medication error is a preventable event. So that may cause or lead to the inappropriate medication use or a patient harm while the medication is in the control of healthcare professional, the patient, or the consumer. Such events may be related to the professional practice, direct practice, or the healthcare products, or the procedures and the systems, including the prescribing, order communication, product labeling, packaging and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. So these are the major areas we need to focus on, which includes the prescribing. If you look at the number of errors happening, if you have a statistics, approximately 54% of the medication errors are happening at the time of prescribing. So when we talk about the medication errors, we always look at the pharmacy. It's not exactly the pharmacy, but majority of the medication errors, approximately 54% of the medication errors are happening outside the pharmacy's window. So what you see in case reports in published literature is just like what we call it as a tip of the iceberg. We started discussing about the safety in healthcare sector after having two important reports from the Institute of Medicine. The first one was published in 1999, and the second one in 2001. Um, when Institute of Medicine published the first report in 1999, the title was "To Errors Human: Building a safer Healthcare System." Public as well as the media was really shocked when they talk about the number of deaths happening in the healthcare sector because of the errors. And this is one of the area where people consider to be a safest place in the world, hospitals. But then they realize that it's not the reality. And comes the second report, which is in 2001, Crossing the Quality Chasm, a new healthcare for the 21st century. They talk about bringing newer technologies to the healthcare system. Then that's the time we started talking about bringing the electronic health records, removing all the paper-based systems, as well as the process automations in the hospitals, including bringing the robotics, the dispensing technologies in the pharmacies, etc. So these two reports were a game changer in terms of medical as well as healthcare safety in general. I really don't know how many of you have a chance to look at the operating rooms in your career period of time. That's a very complex area. You have a patient there, and surrounded by too many people. In fact, you have anesthesiologists, you have surgeons and assistant surgeons, you will have anesthesia technicians, you will have surgical nurses, you will have some hospitals have surgical technicians. On top of that, you will have surgical residents. You'll have perfusionists, especially when you are in a cardiothoracic room. You'll have perfusionists to handle the heart lung machine. And again, you'll have students, medical students, as well as nursing students, or you'll have students from perfusion technology to watch the procedure. So this is a very complex area. If you have a chance to visit, you need to visit these places actually. So as we said already, it's a complexity of perioperative settings. The risk of medication errors or the adverse events during the surgery and anesthesia are raised due to several factors, which includes staffing, which you already saw, newly trained staffs or inexperienced staffs, or the peer pressure or pressure from the situation itself. You could be having an emergency surgery, unplanned surgeries. That's real trauma cases. Medications, multiple medications are administered throughout the perioperative period. High alert medications, the complex list of high alert medication used in the operating rooms, which includes opioids, neuromuscular blocking agents, volatile anesthetics, cardiovascular drugs, etc., etc. So this is a very complex situation. And also the environment is very fast paced. It's so distracting. You'll have people talking about, discussing too many things. There's a lot of distractions in the area. It's a very complex area. It's a dynamic perioperative environment. Also, the range of patients you have, the high-risk patients, which includes geriatric patients or the pediatric patients, the trauma, oncology, renal, and liver, hepatic impaired patients, etc. So you'll have a list of the huge number of high-risk patients, which is vulnerable to the errors. The most important thing is, one of the factor which we can always discuss is the involvement of patient in care actually, but this is not possible always in operating rooms because patient is already sedated. Probably you can just have the initial identification when the patient appears in the area, but after that, once the patient is sedated, there is no patient involvement in fact. So inability of the patients to respond due to the sedation and the anesthesia. The patients will be in a deep coma due to the volatile anesthetics and other sedatives. And the most important thing which I should consider is the one-step process happening in the operating room, which is anesthesia providers. They solely prescribe, they do dispensing, they administer the medication, and they monitor the after effect of the medication. So this is a very, very dangerous, delicate situation, the one-step process happening with the anesthesiologist. And also the ineffective communication. Communication is considered to be one of the very key elements, especially in accreditation process with the Joint Commission accreditation. Ineffective communication can, and the use of verbal orders can lead to medical errors as well as the medication errors in particular. So the perioperative process for the medication usage, as we mentioned earlier, the medication selection, the routine process for the medication usage is the selection of the medication, which is the prescribing, what we call it as the ordering, and the dispensing of the medication, preparation of the medication, administration of the medication, and the documentation and monitoring. And all these 5 to 6 steps are done by a single person. Imagine the monitoring is really complicated. For example, you have to monitor the coma skill, they have to monitor sometimes the RAS score, trainer for the pain scores, the vital signs, the glucose levels, etc. At the same time, with a single person, with the help of nurses or the anesthesia technicians. But the whole process, I would call it as a one-step process. And remember, the interoperative settings are unique because of the single anesthetologist or other member of the anesthesia care team perform all the above mentioned tasks. And there is no routine point at which the mandate the double checking. As we mentioned earlier, the use of high alert medication, one of the important stuff what we need to do for the high alert medication is the utilization of independent double checking, which is not happening at the operating room because it's handled by a single person and it's directly administered by the anesthesiologist. But if it is administered by a nurse, yes, we have to follow the independent double checking process. So that process is not followed in the most of the perioperative in areas. Medication storage in the perioperative area. So you'll find a number of medication kits. You'll have different systems. Some of the hospitals, most developed, the newer hospitals, they are utilizing the automated drug dispensing systems actually, which has incorporated or integrated with the hospital's main electronic health record. I would consider that the automated systems are much safer than the manual storage in the hospitals. This is used not only in the operating rooms; it's used in the any other nursing areas also. And this is considered to be one of the real safer area. And it can, as I mentioned, it can integrate it. It's a lot of capability for these kind of machines. You know, it can integrate it with the hospital EHR and to the point of which dose was administered, who removed the medication, who administered. To that extent, we can track even after 10, 15, or 20 years, and that's really important. The other thing is the medication cards. You'll find different types of medication cards in the operating rooms. You'll have the anesthesia medication cards used only by the anesthetologist, or it might contain a lot of high alert medication, including the volatile anesthetics, etc. Surgical medication kits used by the surgeons. For example, somebody who performs a particular surgery, for example, a cataract surgery, you'll have his own preferences. So these surgeons, they make their own kits so that the medication will be handy next to them. So there is a good possibility of medication mix-up if not managed well by the pharmacist. And the anesthesia kits, especially these kits are used for the purpose of having conducting procedures. Sometimes they will take the patients or they will go to the bedside. For example, to place a tube, for example, a PEG tube near the bedside, they will not bring the patient to the operating room, but instead they will conduct these minor procedures at the bedside itself. So they will have anesthesia kits actually. And also that also contains high alert medications and anesthetics and sedatives. And finally, we'll have the what we call it as crash cards, emergency crash cards, which contains a medication tray. So this is used in terms of if there is a cardiac arrest, we call it as a code blue situation. So most of these medications are high alert. It's a good combination. It's a good collection of high alert medication. So if this storage area is not maintained properly, if it is not maintained properly, if it is not designed properly, yes, you're going to end up with the medication errors. Any medications can lead to an error if it is not managed properly. But most commonly involved medication within the operating room or the perioperative areas are opioids, sedatives and hypnotics, such as propofol, intraoperative or preoperative, postoperative antibiotics, which includes the pre-medications of antibiotics, intraoperative antibiotic. For example, if the surgical procedure causes certain hours, you'll have to dose the antibiotic. For example, if something crosses like 4 hours, for example, you have a neurosurgical cases which last for like 8 to 12 hours, yes, you have to medicate with the antibiotics multiple times. And the vasoactive agents such as phenylephrine. And if you look at the reports, actually 9% of the closed claim lawsuits involve the neuromuscular blocking agents and the muscle laxant administered to a weak patient. This is a very, very dangerous situation. Imagine, administering neuromuscular blocking agent to a patient who is awake and who is not intubated. It's a shortcut to death. We'll talk about the neuromuscular agents in detail in the coming slides. What are the risk factors? Labeling. Improper medication labeling is the most frequently cited risk of perioperative medication errors. What happens in the perioperative areas, anesthesiologist himself prepare the medication in a syringe and he labels it. That's the time there's a good possibility of mixing up the labels, in fact. And another thing is that the duration of procedure, as we mentioned earlier, some of the procedures are really long. It takes a long time for the typical example is neurosurgical cases. It takes always a very long procedures like 6 to 8 to 12 hours sometimes. So those procedures which last for a long time has been associated with the increased incidence of medication errors. One of the factors could be like staff burnout due to the longer procedures. Procedure type, the provider type, etc. Like for example, physical status scores, patient age, and the body mass index have not been associated with the additional risk. If you look at the incidence of medication errors in the perioperative setting, these patients are really at risk compared to the other part of the hospital due to various reasons. For example, the use of sedatives and hypnotics and volatile anesthetics, neuromuscular blocking agents, as well as other high alert medications. But if you look at the literature, you will find a very minimum number of reports in literature uh, just because of the underreporting. So most of the hospital they don't report, and we have various reasons for underreporting for reporting the medication errors, including the work culture. 2007, the U.S. Pharmacopoeia Convention reviewed almost like 11,000 medication errors occurring in the outpatient surgery, uh, pre-operative holding areas, intra-operative areas, and the post-operative settings over 7 years of it. This was one of the massive study conducted by the U.S. Pharmaceutical Convention. And they found that approximately 5% of the errors, 5% of the errors resulted in patient harm, which includes approximately 4 patient deaths. That means we call it as a sentinel events. Patient who experience adverse drug events had a significantly longer hospital stay, and that when we talk about the longer hospital stay, that involves the finance and the cost of money. Surgical patients are 3 times more likely to experience harmful medication errors than the patients in other settings. So they are very vulnerable. Surgical patients are one of the most vulnerable group of patients who might be exposed to medication errors compared to the other hospital admitted patients actually. And the children. The children are they are the highest risk for harm throughout the perioperative continuum. Approximately 12% of the pediatric medication errors resulting in harm in pediatric population. So it's really the incidence is very high in surgical patients, specifically in the pediatric population. Medications like the propofol, phenylephrine, and the fentanyl were the drugs most frequently associated with errors in perioperative areas. Of course, when we talk about the medication errors or any other medical errors, these are the negative outcomes for a patient. So the Institute of Safe Medication Practices, ISMP, they identified the medication mishaps in the operating rooms that have resulted in the negative outcomes for the surgical patients. So we said operating room, so the perioperative area, they saw a lot of medications in numbers, and most of these medications, they fall under the category of high alert medication. So the list of high alert medication, there's a sample list of high alert medication usually prepared by the Institute for Safe Medication Practice, ISMP usually, and they frequently review this list, in fact. So if somebody want to see this list, you can just approach the website from the ISMP, and you'll find that list. And if your organization, your hospital want to adopt, you can just adopt the same thing, and you can just make the modification based on your local settings. So high alert medications are the drugs that bear the highest risk of causing significant patient harm when it is used by error. So although these mistakes may not be more common, with these drugs, the consequence of an error, they're clearly more devastating to the patient. So doesn't mean that we don't look at the number of medication errors happening due to the high alert medication, but when it happens, it could be a devastating or sentinel event or life-threatening situation. So that's why the Institute for Medication Safety safe medication practices, they classified this group of medications as high alert medication. So each of the organizations should have a very clear policy, especially if you're planning for the accreditation service, for example, a joint commission or even the NABH accreditation. This could be one of the major topic where the medication management survey should focus on. So what are the medications commonly used in the perioperative process? It's a wide range of medication, which includes the neuromuscular blocking agents. We have the epidural medications, intrathecal medications sometimes, cardioplegic solutions. Cardioplegic solutions are used in the cardiac procedures, especially in coronary artery bypass grafting. Actually, so basically the function is to stop the heart. The purpose of cardioplegic solutions to stop the heart, and the reason why it stop the heart is simple. It contains a very high concentration of potassium. Okay, so cardioplegic solution, and one thing you need to really remember, I don't know how does it appears in the Indian market, but I can see here it appears as a, it looks like very similar like an IV bag. There is a good possibility that somebody can infuse to the patient, so that will be a shortcut to the death. And the concentrated electrolytes, anti-thrombotic drugs, insulins, a different kind of insulins, anesthetic agents, which includes the volatile anesthetics, adrenergic antagonist as well as agonist, anti-arrhythmic agents, which includes amiodarone injection, etc. So these are the very most common high alert medication used or available in your perioperative settings. So basically, you should have a special precaution to handle these medications. What we do is, or most of the hospitals do, is they will have a separate labeling for all these high alert medication, which says that high alert medication. You know, it's a very bright red labels we use it here. So what else you can do for safeguarding the high alert medication? Number one is in your organization to have specific policy for handling the high alert medication. For us, or the most of the international organization, they mandate on the independent double checking at the time of administration. That means two capable healthcare professionals or who is credentialed to administer that drug should independently double check this medication. So this is a basic process for any of the high alert medication. But if you look at the perioperative areas, the practicality is really difficult because, as I mentioned earlier, it's been handled by a single person. The whole scenario is handled by a single person, which is an anesthesiologist. So there is no independent double checking happen. So that's another drawback in the perioperative area. If you have an electronic system, you can easily set an electronic alert at the time of dispensing. If you have an automatic drug dispensing system, the screen can show a message that you're going to remove a high alert medication, and you can even enforce a forcing functionality, what we call it as an double checking or the second witness for removal of such medication from the areas. You can have the cautionary labels, which I mentioned earlier, which says that high alert medication. Standardizing the concentration is very important because, you know, rather than having different concentrations of this medication, standardize, procure only the standardized concentration. And you should have a standardized IV administration guidelines in the hospital, which involves IL medication and all other IV administered medication, so that it can reduce the number of medication errors related to high alert medication. Also, you can incorporate the IV administration guideline to your electronic health record, so that, you know, somebody doesn't have to actually remember what is the dilution. So it's already incorporated. And the most important thing here is remove the unnecessary high alert medication from the areas which is not used. For example, if it is a general floor, general medical floor, why you have to keep a neuromuscular blocking agent there? Remove it from there. So it's not used, in fact, there. And that's really a risk. So since we are talking about the neuromuscular blocking, I mean, the perioperative area, one of the main focus which I need to speak about is safety of neuromuscular blocking agents, which we had a brief introduction in the previous slides. So neuromuscular blocking agents should be segregated, sequestered, and differentiated from the other medication wherever they are stored in the organization. This is very important. Most of the organization, this is one of the major recommendations from the Institute of Safe Medication Practice, ISMP, along with the targeted medication safety best practices for the hospital, which was published 3 years before. And again, if you're an accreditation survey, yes, this will be one of the focus point for them. This particular event, there is a big tragic event happened in Syria a few years back, in fact, a medication mishap, which is related to the neuromuscular blocking agent. It's not, it doesn't happen in a perioperative area, but I just want to share this information with you because this involves a neuromuscular blocking agent. So there was a mass immunization program going on in one of the cities in Syria. They were vaccinating kids with measles vaccine, and unfortunately, one of the staff picked up atracurium from the refrigerator instead of measles vaccine. You can just imagine very active young kids, okay, in a public place with there's no life support, there is no intubation. 70 of them were administered with atracurium without intubation. And 15 young kids, they died, who were between like 6 to 18 months old. This was one of the major tragic events. And here comes another second case related to the same kind of neuromuscular blocking agent. A patient from Vanderbilt University Medical Center in US. Patient name was Charlie Murphy. Patient was taken to a positron emission tomography. That's a PET scanning. It's a procedure. So most of these patients who have been usually taken to the scanning or this kind of procedures, they'll be very anxious. So what we do usually is we'll give a small dose of anxiolytic agents. Sometimes we'll go for a lorazepam, and this particular case they selected a midazolam. And the brand name for this midazolam for that particular environment was Versed, and the physician wrote he particularly prescribed for the Versed. So this is a state-of-art hospital which have the automated drug dispensing system. They have EHR everything, and they got a very good system there. And actually, in fact, this patient, this particular staff was supporting a neurosurgical area, neurosurgical ICU, and she was associated with the training also. And she was assisting one of the nurses, and in fact, she was a float nurse to that particular area. And she was notified to administer IV Versed for Charlie Murphy. And now you can see what happened for this patient now. So she went to the ADS, which is the automated drug dispensing system. So I don't know, the hospital settings, we have different kind of systems here. We have electronic health records. We have the automated drug dispensing systems in various areas. There are two different major kind of electronic automated drug dispensing systems in the hospitals. One, we call it as the profile stations, where the profile stations are, it contains the medication profiles of the patient, which is already pre-verified, pre-reviewed clinically by the pharmacist. So only those medication which is reviewed, prescribed by the physician, reviewed by the pharmacist will appear on those screens. So they have no way to access other medication. They just go to the medication patient name and the medical records number, access the medication listed under that patient. That's all. So we call it as a profile stations. And then another group of ADS, automated drug dispensing systems, which is widely used in the procedural areas, in the operating room, perioperative settings, and the clinics, we call it as a non-profile stations. The drawback with the non-profile station or non-profile profile setting is that nurses can go to the patient name and access any medication. So they search the medication by either by generic name or the brand name. So since this particular staff were new to that area, so she was trying to search the medication using a brand name, which is a Versed. So what most of the people they do is they use the first few letters to search. She searched VE. She just used the first two letters for searching. And the first thing appeared for this particular search result was vecuronium, which is another neuromuscular blocking agent. She administered the medication, and the patient caught it in a few minutes and died. So this is one of the another mishap happened along with the neuromuscular blocking agents, and you can just see this photograph. She's sitting as on the first row, on the second person on the first row, and she's facing the court now. Even though this particular incident is not actually, most of the people say that it's an error, but we need to, when we discuss about the medication errors or the medical errors, the first thing we need to look at is there any system failures. Most of the medical and the medication errors are happening due to the system failures, due to the system related issues. You have a inappropriately designed system in your hospital. That's why the errors are happening. It's not because of somebody is doing intentionally. If somebody is doing intentionally, that's a different scenario. This is not a intentional case. This is a mishap happened just due to the system failure. So, like for example, again, we have the medication, ISM, we have come up with the targeted medication best practices for the neuromuscular blocking agents. So they have their own recommendation, which we say is that remove the neuromuscular blocking agent from the areas of the hospital where they are not routinely needed. We need to remove all those medications. If the neuromuscular blocking agents are needed for the patient, especially in the critical areas, emergency department, they should be placed in a sealed box with a specific label, or we can use it as RSI kit, which we call it as a rapid sequence intubation kit, which contain couple of medications like succinylcholine, the atracurium or vigronium, etc. So it should be really secure. If the institution stores the neuromuscular blocking agents in the automated drug dispensing cabinet, there should be a standardized storage practices throughout the organization and should be placed the neuromuscular blocking agents in the locked lidded pocket. So they should be able to access only that particular medication when they try to access it. Neuromuscular blocking agents should be segregated from all other medications and should be placed in a separate lidded containers in the refrigerator or in other secure isolated area. The purpose is to avoid the mix-ups. And again, we have slides coming up regarding the lookalike, sound-alike medication after a few slides. So auxiliary labels, the most of the organization, they use the auxiliary labeling, which clearly mentioned that the patient should be intubated if we are using the neuromuscular blocking agents. So these are some of the examples for the auxiliary labels. You can see the succinylcholine label. It very clearly says that it's a paralyzing agent. It causes respiratory arrest. Facilities must be immediately available for the artificial respiration. So basically, the patient should be intubated or patient should be planning to be intubated. So or the respiratory support should be available. Life support should be available next to the medication, next to the patient for the support. And these are some of the labels which most of the organization, I mean, you can see the lid of the medication which says a paralyzing agent. And here comes the second group of medication, which is really, which causes medication errors, which is the concentrated electrolytes. So concentrated electrolytes may be described as a solutions manufactured and distributed with the intention of being diluted prior to the administration. So one of the most important thing you need to remember, all these concentrated electrolytes must be diluted before the use. So you can use the precautionary label, what you can see in the screen here, must be diluted before use. Some of the examples for the concentrated electrolytes are the hypertonic saline, which is anything beyond 0.9% is considered to be hypertonic, and any hypertonic solutions are considered to be a part of high alert or the concentrated electrolyte. Sodium chloride concentrated solution, potassium chloride, which need a very special attention in your organization. One of the drug which need a very special precautions and attention, specifically for the use, never been used as a concentrated solution. Sodium bicarbonate solution and the magnesium sulfate 50% solutions. These are the very common solutions used in the perioperative settings as a concentrated electrolytes, which is another high alert class of drugs. So concentrated electrolytes, there's a possibility of accidental administration without first dilution. So this is one of the real challenge for this kind of medication. That's why we always say that we should have the special precautions for using the concentrated electrolytes. So some of the clinical areas where we stock the concentrated electrolytes, which includes the crash cards, which is for the cord blue timing or the cardiac arrest, which is located in the critical areas, emergency room or the procedure areas or the interventional suites, etc. We'll have it in the emergency response medication kits. In the ambulances, you can see these medications. In the emergency rooms, you can see they have the transportation bags. Some of them have the concentrated electrolytes. Cardioplegic solution, which I mentioned earlier, which is used in the cardiac surgical program, especially the cardiac coronary artery bypass grafting solution in the procedure, particularly used to stop the heart for the period of surgery. So one of the reasons why it induces a cardioplegia is that it contains a high concentrated potassium chloride. It needs a special precaution. And some of the risk factors are the improper medication administration techniques used in the operating rooms and the procedure areas. Syringe on the needle reuse, which is really risky. We should not be encouraging this procedure. Improper use of multi-dose vials leading to the morbidity from the infections and diseases, probably the hepatitis C virus. We have seen in the past few years before there was a case report of multiple patients appeared post-operatively or the post-procedure, which was the result of contaminated methyl prednisolone prepared in the pharmacy services in one of the areas in the US. So this was one of the very notable case report a few years before. Contamination again, which I mentioned earlier, the fungal outbreak due to the methyl prednisolone acetate, which happened in the compounding pharmacy in one of the hospitals, is a very typical example. It can occur in the manufacturing level or the preparation level, or in the cases where the drugs are provided by the compounding pharmacy. So the external, if you're depending, some of the hospitals, some of the countries, they depend, for example, the countries like US, they depend compounding services, external compounding service. That means someone else, the other compounding service, the external pharmacies, services, they provide the compounded items for you. So well-documented outbreak of fungal meningitis due to the changed epidural steroid solutions that was traced back to the single compounding pharmacy that was prepared for the steroids. So this is one of the typical example we got always for the medication safety in terms of contamination. And other issue in the perioperative area is the communication, verbal, and usually we don't go for the routine telephone orders in the perioperative settings, but verbal orders are one of the most common, and the other interruptions. So communication is the key. So verbal orders are common from both surgeons as well as anesthesiologists and other care providers. However, these orders are not to be always very clear due to various reasons. For example, um, particularly if you're working in a multicultural, multinational environment with a different dialect, you'll have different kind of pronunciation with the different nationalities. So, the perception will be something different from person to person. And especially use of surgical mask and the muffled image, the message or the order. So you cannot listen what exactly you've been verbally ordered. It's because of the use of surgical masks, and especially nowadays we have the additional precautions, the PPEs now in the COVID scenarios. And also, it's very interesting to share that some of the hospitals, some of the surgical teams, they play background music during the procedure, especially for the procedures which continue for a very long hours. They play the music, in fact, in the OR, and there will be a lot of alarms which comes from the monitors, from the anesthesia machines, etc., or other various distractions in the room. So verbal orders should be always discouraged in the healthcare settings, particularly in the perioperative area due to various reasons. Lookalike, soundalike products, it's very common, especially nowadays, since we started using a lot of generic products in the market. Every vial, every ampule, every tablet the packing looks almost same. You can just see the packages here for the two medication, which is, the number one is Vicronium as well as Flumacinin. It looks typically same except the cap. The labeling is almost same, and it comes from the same manufacturer. And look at the difference. The Vicronium is a neuromuscular blocking agent, whereas the Flumacinin is an antidote for drugs like diazepam. The other product you can see is Vicronium and the vancomycin. Even the first letter is the same. The V start with a V, and the package is almost same except the cap. So this kind of formulations are very common in healthcare settings nowadays because of various reasons, and the medication errors may be. What are the strategies we use to tackle this um, problem in the healthcare setting is to use the Tolman lettering. So what is Tolman lettering is that, you just, if you look at the how the dopamine and dobutamine is written in the screen here, that the dissimilar part of the the dissimilar part of the drug name is being written as a capital letter. You can see the dop is separate and the amine is it's separate. So what is common with two names is amine, the last four letters. So we will highlight the first three or four letters, which is dissimilar, so that the provider can identify. So if you have a system, especially if you have a electronic system in the hospital, if you have automated drug dispensing system, it should be very uniform all over the hospital, starting from the prescribing to the administration to the electronic documentation everywhere. If you have a policy for the Tolman lettering, lookalike managing lookalike sound-alike product in your hospital, it should be uniform throughout the hospital, including the labeling and everything in the hospital. Any documentation should follow if that particular medication is a part of the lookalike medication list. So basically, you should have a policy to look at to review or a frequent method of reviewing this kind of products, especially when you receive first time or when you add this medication into the formulary, and you need to really look at if it resembles to any other existing product in the hospital already. If there is a possibility, try to procure another medication. I mean, another manufacturer. Go for the separate provider or the manufacturer to get a different product, which is looking literally dissimilar. And the second step is that you should prepare a list of medications, list of lookalike, sound-alike products, which is available in your hospital. And the staff, especially the frontline staff, including the pharmacy nursing as well the physician, should be very familiar with this kind of medications. Um, and you need to identify, segregate, and label it properly with the caution label, which says that lookalike, sound-alike medication, take precautions. Communication is another issue, um, especially when you're doing the handoffs. You hand over the patients from groups to groups. Actually, for example, if you're receiving the patients from the pre-operative area or the holding area to the operating room, you complete the process. Or operating room procedure is completed, and you're going to hand over this patient to the post anesthesia care area. And from the post anesthesia care area, you're going to transfer that patient back to the either a critical care area or the step down to the regular area. So every transition of care, every handout, whenever there is a change in the team, you have to provide a standardized handoff. Whatever the way you are using, whatever the format you are using, it should be standardized throughout the hospital, and the whole team, the staff members should be familiar with the handoff method. One of the very common method used for the handoff is the SABA method, which is a situation background assessment recommendation, which is recommended by the Institute for Healthcare Improvement, IHI, from USA. So S stands for the situation, B for background, assessment, and recommendation. So this is one of the very commonly used handoff method in most of the reputed hospitals. Coming to the physicians as well as the pharmacists, we play a major role in perioperative medication reconciliation. Basically, medication reconciliation process where you collect the information about the patient, what medication patient was taking prior to the admission or prior to the process, and what need to be taken at that particular time or during the case of admission, and what need to be continued. So basically, there are medication reconciliation should be done in all the transition of care. So what do you mean by transition of care? Transition of care, there are different transition of care in the hospital. The most common settings are admissions, transfer, um, pre-operative and the post-operative, discharge, as well as when you transfer this patient from facility to facility. That means if you are transferring the patient from one hospital to another hospital. So these are the major areas where you have to do a reconciliation. So if there is a transition of care involved, you have to do a medication reconciliation. So perioperative medication reconciliation is most important to reduce the number of medication errors for such patients. You can have different methodologies to which is suited for your hospital. You can do a proper medication reconciliation in the pre-admission clinic, because most of the hospital have pre-admission surgical clinic or surgical evaluation clinic. Patient comes to the clinic if there is a planned procedures. They come to the clinic for before the procedure, a couple of days before or a week before, and at that time, a physician can do a reconciliation. And this is very important, especially if the patient is on certain medications, like for example, anticoagulants, drugs like warfarin, or some other drugs like, which increases the risk. For example, they'll have to stop this medication for certain period of time, for example, like a week or something. So preoperative medication reconciliation is very important for the safer patient transition. And one of the main factor here is why we have to do a perioperative medication reconciliation, which is directly linked to the accuracy of the postoperative or the discharge reconciliation. A solid and accurate medication reconciliation process at the admission simplifies the discharge medication reconciliation, because the discharge medication will have greater chance of being accurate if the admission medication list is properly done. And here comes the pharmacist collaboration in the perioperative care. Many of the reputed hospitals have specialized pharmacists working in the perioperative area. We call it as operating room pharmacists. They are trained well in perioperative settings. They have different functionalities, in fact, and they are really a key component in reducing the medication errors and the patient safety in the perioperative area. So what can be done? What is our role as a pharmacist in the perioperative settings? You can perform different roles here. Number one is the teaching, what we call it as a continuing professional development programs, arranging the programs for the staff, which includes the anesthesiologists, the pharmacists, other fellow professionals, the nursing staff, the anesthesia technicians, and nursing technicians, etc. And also the pharmacists will be involved in the M&M rounds, what we call it as morbidity and mortality rounds. Frequent rounds are happening in the hospitals. And also prevention of narcotic diversion. See, this is one of the very vulnerable area in the hospital, in the healthcare settings, where we can have a narcotic diversion. So we can keep an eye on the narcotic diversion in the hospital, antibiotic, or even we can get involved in what we call it as something. There is a new terminology coming up, what we call it as narcotic stewardship. That's one of the newer terminology coming up, like antibiotic stewardship. So also the antibiotic stewardship, antibiotic utilization process is another area where pharmacists can actively participating in the perioperative area. Also, at the end of the day, we can go for an auditing to what extent physicians, anesthesiologists, and surgeons are how frequent they are compliant to the medication utilization process, especially in terms of narcotic medication, anesthetics, etc. You need to compare the medication utilization, and if there is a gap, you need to notify the units, and you need to find a way to use it properly. So these are the selected clinical pharmacists. They play a major role in the perioperative area for various reasons, actually, and they work along with the surgeons and anesthesiologists and the nurses, very close to each other. Especially, they can play a major role in patient safety. What a pharmacy can provide in terms of medication is that we play a major important role here as a normal pharmacist, and number one is always in a perioperative area, in the surgery, during the surgery, we always recommend to use the pre-filled syringes rather than the surgeon or the anesthesiologist prepare the syringes at the time of procedure. You can see that we already mentioned about the one-step process, where as an anesthesiologist, he prescribes the medication, he dispense the medication from the ADS or from the kits. He prepare the medication for the patient, administer it, and the monitor. So the whole process is done by the anesthesiologist. So it's better you can give some relief for this group of persons by providing the pre-filled syringes or the premixed solution, even similar to the pre-filled syringes. Or you can have, as we discussed earlier, you can support them to avoid the use of lookalike, sound-alike medication coming from the pharmacy at the time of purchasing itself or the procuring itself, and avoid the multi-use drugs. In fact, the multi-use vials, that causes a lot of risk, especially the open vials, and it's better to make a practice of just discarding the multi-dose vials at the end of each cases. It's better not to use it. And finally, as we discussed, the clinical pharmacists involved as a consultants in perioperative areas, they play a major role in preventing medication errors and adverse medication events in those surgical settings. And again, we can go for the technology. We slightly mentioned about the technology in the previous slide. The different technologies available. Most of the hospitals, well-designed hospital nowadays, they don't use the paper-based documentation anymore. The whole process is automated. The whole process is computerized. It's basically like you'll find a paper-free environment in most of the reputed organizations now. So what we call it as a computerized provider order entry, where physicians make all the orders, including the labs, including the medication procedure, everything through the system. So when it comes to the medication, so these orders will come to the pharmacy queue for clinical review, and we do the clinical review at that point, and then once it is reviewed and approved by the pharmacist, it goes to the nursing screen for administration. That's what exactly happened in the electronic world. And at the time of administration, there are hospitals, including where I'm working. We use the barcoded medication administration technology, where each minute dose is barcoded, and at the time of administration, the nursing or the physician has to scan the barcode to document the medication administration in the system. So basically, this is one of the major steps to avoid the medication errors, to identify the correct medication. We call it as a 5 rights. So this actually protect one of the 5 rights, the right medication. And also, you can just see that the hospitals, the patients are nowadays barcoded now. They have a wristband with a barcode. So basically, you can identify the patient using scanning a barcode in the wristband, and then you can go for scanning the individual dose to identify the right medication. So these technologies are used successfully in most of the hospital nowadays, with almost like more than 95% compliance in the hospital. The other technology, which is not that common around like BCMA, it's radio frequency tagging for the medication, which is very similar, but there are a little bit advantages compared to the barcoded medication administration for the RFIDs. RFID, you don't need a proximity of the scanners near to you. You can just install the receiver anywhere in the hospital or in the proximity in the room. And that can actually at the one time, it can scan or identify hundreds of signals at a time. So there are hospitals which utilize the RFIDs for the medication management. Technology, yes. There are limitations for the technology. This particular system is used in the anesthesia works. This is anesthesia workstation. What you see in the screen is an anesthesia workstation. People say there are a lot of limitations for the technology, but again, one of the major limitations, what most of the people say, is affordability. But when you compare the compensations what you're going to give in terms of medication errors or the medical errors, I think affordability should not be an issue for any of the reputed organizations. So you should not consider the finance as a major issue or drawback for the bringing the technologies to the pharmaceutical services. Dynamics is that this is very important here, especially when you have frequently changing the brands. You'll have new products coming up frequently. And only thing is you should have a very supportive pharmacy informatics and the hospital informatics and the formulary management team to support your system, to update and to add more things to your electronic systems for the formulary. There are a group of people who says that it delays the process, but in my personal experience, it actually, our turnaround time have significantly improved when we started the automation a few years before. So, but there are people who always complain about the delays and the popularity. One of the reason why this kind of technology is not popular is probably because of the affordability. It costs a lot of money. Every organization should have a policy or strategy to have for the risk reduction. And you can just say that we are trying harder, but that will not resolve the issue. But we should come up with a proper strategy for any hospital healthcare system to reduce or guarantee the avoidance of errors. How do you detect and report the errors in the hospital settings? There are too many methods. In fact, you can do the self-reporting system. You can have the mandatory incident reporting system. You can have like a chart review, computerized surveillance system activated on if you got an electronic health record for your hospital. And also you can go for a direct observation with the trained people during the surgical procedures and other perioperative areas. So there are different methodologies. But most important thing apart from all these methodologies that, creating a proper, safer, healthy environment for the staff to report the medication errors. Not only the medication errors, including the near misses. So near misses are the events which doesn't reach to the patient, but um, the importance of near miss reporting in any organization is that it triggers the usually the managements for something which a system related issue which they can resolve it. And also it gives a proper trend what's happening in the hospital. There is a design issue, a system related issue, we can find out from the near miss reporting. So reporting a near miss, encouraging the staff to do a near miss reporting is really important for a safer healthcare settings. But again, you'll have to do a lot of campaigns to have such an environment, because to create a blame-free environment, especially in the healthcare system, it's a bit difficult, but that's possible actually. Only thing is the administration have to work a lot behind the screen. So to conclude, the medication errors or the medication safety, it's directed to the patient safety, and also on top of the a direct threat to the patient safety, it involves a lot of economic burden to the patient family, especially if you are in the Indian environment. You can just imagine our insurance coverage is very limited in our population, and the expense is taken by the families and the persons individually. So it involves a lot of economic burden, not only for the patients and family, as well as it involves burden for the hospitals if somebody goes to the court or to the government. Also, it's a burden for the whole society, in fact. So medication errors are multifactorial. So there's not a single answer. Why the medication errors are happening in the hospital, I don't have an answer, a single word answer to say. It's just, I could say that it's a multifactorial. And one of the strategies used in most of the hospitals keep doing the independent or the double checking to identify and report the possible errors or the loopholes. And as we mentioned earlier, use the latest technologies to reduce the medication errors. And finally, the LTA organization should create an environment for reporting them. And this is very important to create a healthy, blame-free environment for the staff to report any, including a minor event, including a near miss happens. So thank you so much once again for this invitation.
Thank you so much, sir. I think something that we've clearly noticed is you've got a very in-depth experience and knowledge with the very operative area. And right from the beginning of the presentation, sir, we see that pharmacist has a very important role, whether it be from packaging, labeling, dispensing, or even if it is inside the operation theater. And you did mention about the roles or the possible scope of a clinical pharmacist. And looking into our list of participants, the major chunk of participants that we have right now are a lot of pharmacists, and many of them would be going out for jobs, clinical or industrial. So, could you give them directions on how they could, if they want to work in the clinical scenario, if they want to work in the clinical setup, especially associated with perioperative and operative conditions, how could they go about, whether it be with training, examinations, how could they advance their experience in this field?
Okay. Yeah, there are organizations or the universities providing the residencies in surgical care for the pharmacists, in fact. And usually we talk about the board certification, but unfortunately there is no board certification for the specialty in perioperative or surgical. They have the usual pharmacotherapy. They have
Yeah.
specialties in cardiology and oncology and all those things, but there's nothing in the perioperative or surgical care. But mostly, you should be lucky enough to have a good preceptor where you'll work in the hospital actually, or in a good hospital. Yes, it's by training, by your experience. At this point of time, I don't think is there any organization providing a certification in surgical areas for the clinical pharmacy certifications. But again, it's mostly the experience, but there are residencies available in certain universities. Yes.
Yeah, like you mentioned, so we don't have a certification with surgery, we have it with many others. So, how did you get introduced to this field, sir?
Okay. So it's quite interesting, actually. My story is I joined, in fact, I started my career after completing my master's degree as a teaching faculty in one of the organizations in India. I was a faculty in JSS College of Pharmacy, Mysore for a couple of years. Then I got hired with what we call it as Saudi Aramco Medical Services Organizations in 2000 October. That's 20 years back, in fact.
Okay, okay,
Uh,
okay.
I served in many areas, including ambulatory care,
Yeah.
including the emergency areas, including critical care areas, including the surgical ICUs. And almost an year, I served for the operating room pharmacist.
Okay.
So I had a chance to work with the operating. So we have like number of operating rooms, so which includes almost like 12 operating suites and the cath labs.
Yeah.
We have a perioperative area etc. So it's mainly by experience, and we got a lot of continuing education programs, live here to develop yourself.
Yeah. Okay, sir. Thank you so much for sparing time for us. Thank you for sharing
Once again, thank you
that
so
medical
much
knowledge.
for invitation, actually. And
Yeah.
do we have any questions from students?
Not yet, sir. Do any of the participants have any questions to ask Dr. Rajesh? Okay, thank you, sir. I think they do not have any questions.
That's because this is a very specialized area because the people are not exposed to that area. That's the reason.
Yeah. Okay, sir. Thank you so much for your informative talk, and we will see you soon, sir.
Thank you so much. Thank you.
Thank you, sir.